You know, there's this really deeply ingrained assumption we all have when we go in for, well, pretty much any kind of medical procedure.
Right, like you need a totally sterile environment.
Yeah, exactly. This whole idea that you need a clean slate, like you're, I don't know, prepping a canvas or something.
Right, you wipe away all the daily lotions, you stop taking your supplements, you pause all the topical medications.
You just let the doctor work with this untouched, completely isolated surface.
I mean, it makes total sense. That is standard operating procedure for a lot of things.
It makes complete logical sense, but what we're looking at today completely shatters that assumption.
It really does. It flips the whole concept on its head.
So welcome to today's deep dive. We are jumping into this massive stack of medical guidelines, clinical trial data, and expert commentary.
And it's all centered entirely around pelvic health and basically regenerative medicine.
Yeah, specifically, we are zeroing in on one really crucial question for anyone out there looking at advanced vaginal rejuvenation procedures.
This is a rapidly growing field, by the way.
It is. So the big question we're tackling for you today is, should you pause your local estrogen therapy before you undergo an elective, energy-based laser or injectable treatment?
And what's fascinating here is that the medical field is undergoing this fundamental evolution in how it handles what is clinically known as genitourinary syndrome of menopause, or GSM.
Right, GSM.
Yeah. We are witnessing this massive shift from just trying to manage uncomfortable symptoms to actually regenerating the physical tissue.
Which is wild.
It is. And the relationship between the hormones you apply at home and the high-tech equipment in the clinic is really where the breakthrough lies.
Okay, let's unpack this. Because your first instinct listening to this is definitely going to be, I'm about to get a high-tech laser treatment, so I need to stop all my hormonal creams and give the doctor that clean slate.
Right, the canvas analogy.
Exactly. But the data we have in our sources here says the absolute opposite.
The exact opposite, yeah.
But to understand why that protocol is flipped on its head, we kind of have to look at what GSM actually does to the body first.
We do. And we should probably emphasize, this is not some rare edge case condition.
Oh, not at all. The sources point out that this affects up to, 84% of postmenopausal women.
84%. It is an incredibly common, chronic, and, unfortunately progressive condition.
It doesn't just go away.
No, it gets worse over time if untreated. When a woman's systemic estrogen levels drop during menopause, the actual architecture of the vulva, the vagina, and the bladder fundamentally changes.
Because we rely on that estrogen, right?
Exactly. These are highly estrogen-responsive tissues. So without that constant hormonal signal, the tissue literally thins out.
Oh, wow.
Yeah, it loses its elasticity, and the local blood flow drops significantly.
Well, it's not just a physical thinning of the walls, right? There's a whole chain reaction happening with the chemistry down there.
Oh, absolutely. The chemistry in the microbiome, the lack of estrogen, completely alters the local environment.
How so? What actually changes?
So under normal premenopausal circumstances, estrogen helps produce glycogen in the vaginal epithelium.
Okay, glycogen.
Right. And the glycogen is basically food for lactobacilli, which are the good bacteria.
Oh, I see.
So the lactobacilli eat the glycogen, and in turn, they produce lactic acid, which keeps the vaginal pH low and acidic.
Right, and an acidic environment is hostile to the bad bacteria. It's basically the body's natural defense system.
Exactly. So when estrogen drops, the glycogen drops. The good bacteria essentially starve.
Oh, no. So then the pH goes up.
The pH shoots up, and suddenly that natural immunological barrier is completely compromised.
Which opens the door for all sorts of issues.
Right. This makes the area highly susceptible to opportunistic infections. The result is this cascade of really severe symptoms.
Like what kind of symptoms are we talking about?
Intense dryness, burning, itching, urinary urgency, recurrent urinary tract infections, and incredibly painful intercourse.
Which they call dyspareunia, right?
Yes. Clinically known as dyspareunia.
So the traditional medical fix, for decades has been to just put the estrogen back.
Right, replace what's missing.
But specifically local estrogen, I love this analogy in the reading. If systemic hormone replacement therapy, like taking a daily pill or wearing a patch.
The full body approach.
Yeah, if systemic HRT is like trying to change the weather over the entire planet just to water one specific garden, then local estrogen is like taking a tiny watering can and using it exactly where the soil is dry.
That is a perfect way to visualize it, because systemic HRT circulates through the entire bloodstream, right?
Right, it goes everywhere.
And it carries well-documented risks for some women. Things like venous thromboembolism, or an increased risk of certain breast and endometrial pathologies.
Because it's systemic, it's hitting all the organs.
Exactly. Because of those broad systemic effects, major medical societies do not recommend systemic HRT solely for managing pelvic floor issues.
They prefer the watering can.
They do. Local estrogen, which, comes in low-dose creams, rings, or tiny tablets, it works directly on the target tissue with extremely low systemic absorption.
So it's super targeted.
Very targeted. It restores the thickness of the walls and restarts that whole glycogen feeding cycle without changing the whole body's chemistry.
The catch we keep seeing in the sources, though, is that local estrogen isn't a silver bullet for everyone.
No, it's really not.
Like, the creams can be messy. It's a lifelong commitment because the moment you stop using it, the thinning and the symptoms come right back.
You have to keep watering the garden.
Exactly. And for a significant percentage of women, they use the local estrogen religiously every single day, and they still do not get adequate relief.
Right. And when those chemical messengers hit a ceiling, that's when the medical field started looking for a totally different approach.
They have to get creative.
They really did. If the hormones cannot reverse the atrophy on their own, doctors started asking, well, what could physical energy do?
Right.
So they took the kind of technology you would normally see in a dermatologist's office for anti-aging, and they brought it to gynecology.
Which brings us to segment 2. We are looking at basically 3 main categories of these new regenerative therapies in our stack.
Right. First, you have the lasers, specifically fractional CO2 lasers and erbium-YAG lasers.
Often just called ERAG.
Got it, ERYAG. Second, you have radiofrequency, or RF devices. And third, you have the injectables, most notably the O-shot, which uses platelet-rich plasma derived from a patient's own blood.
Right, PRP.
Okay, wait, hold on. Because I'm looking at this list, and we were talking about shooting high-powered lasers and thermal energy into tissue that we just established is like paper-thin, dry, and incredibly sensitive.
It sounds counterintuitive.
It sounds almost medieval. How on earth does that not just cause third-degree burns? Take a laser to an atrophied vaginal wall.
It sounds terrifying until you look at the underlying mechanism. If we connect this to the cellular level, it is not about burning in a destructive, carbonizing sense.
Okay, so it's not like a surgical cutting laser.
No, not at all. It is highly controlled, low-temperature thermal manipulation. The erbium-YAG laser, for instance, uses a specific mode. It's often called smooth mode.
Smooth mode, right. And it distributes heat into the mucosa, but it only reaches temperatures between 45 and 60 degrees Celsius.
Wait, 45 to 60 Celsius? That's essentially warming the tissue to the temperature of hot tap water.
Exactly. It's not incinerating it.
Okay, that makes me feel a lot better.
Right. That mild controlled trauma is actually this incredible biological trick. It acts as an alarm bell for the cells.
An alarm bell.
Yeah. The heat activates something called heat shock proteins. Think of them as basically cellular emergency responders.
Oh, I like that.
When they detect this sudden thermal stress from the hot tap water temperature, they rush to the area and trigger a massive healing cascade.
So they panic in a good way.
In a very good way. They stimulate neocollagenesis, which is just the building of brand new structural collagen fibers, and angiogenesis, which is the sprouting of new blood vessels.
So the body thinks, oh no, there's an injury here, send all the repair materials immediately.
Precisely.
In the process of fixing this tiny artificially induced injury, it accidentally rebuilds the entire foundation of the vaginal wall.
It is the exact same mechanism dermatological lasers use to remodel the skin on the face, right? To clear up acne scars. Stimulate collagen.
Oh, sure, like Fraxel.
Exactly like Fraxel.
Yeah.
It is just being applied to a different epithelium. And the PRP, the O-shot we mentioned, works on a similar principle.
But without the heat.
Right, without the heat. You spin down the patient's blood in a centrifuge, you extract the concentrated growth factors and platelets, and inject them to trigger that same localized regenerative healing cascade.
Which brings us to the core question of this whole deep dive, the thing we started the episode with.
The clean slate question.
Yes. If someone is currently using their local estrogen cream and they decide to go in for one of these fractional CO2 laser treatments or a PRP shot, do they stop the estrogen?
Do they pause the watering can?
Exactly. Do they pause the watering can to let the laser work on a clean slate?
The overwhelming consensus from all the clinical data in our sources is no. You absolutely do not pause the local estrogen.
Which is why.
In fact, combining them is highly recommended.
I love this because it completely flips the standard protocol on its head. But why? Why do you need both? Why not just let the laser do all the heavy lifting?
It comes down to a physiological concept called tissue priming.
Tissue priming. Okay.
Vaginal estrogen is actively prescribed for 4 to 6 weeks before advanced treatments like a laser or PRP injections.
So it's a preparatory step. You are getting the tissue ready to be traumatized by the laser.
Exactly. Think about it. If a patient has severe GSM, their vaginal tissue is incredibly fragile, and it lacks proper blood flow, right?
Right. It's basically starving.
If you fire a laser or inject plasma into severely atrophied tissue, the body simply doesn't have the biological resources to respond to that alarm bell we just talked about.
Oh, I see.
The heat shock proteins might sound the alarm, but there's no cellular machinery or blood supply there to actually build the new collagen.
Mm.
The emergency responders show up, but they don't have any bricks or mortar.
Oh, wow. It's like fertilizing and tilling the soil for a month before you plant a new seed. The laser or the PRP is the new seed. But if the ground is completely barren and dry and thin, the seed just won't take.
It can't take.
The estrogen prepares the ground, it gives the tissue the structural integrity and the baseline blood supply it needs to actually mount a robust healing response.
You nailed it. The estrogen handles the hormonal foundation, and the device provides the targeted structural stimulus.
That makes so much sense when you explain it that way.
And for PRP specifically, having proper estrogen levels physically enhances the tissue's ability to lock onto and respond to the regenerative signals from the injected plasma.
To literally work better together.
They do.
Oh.
And we are seeing this synergy play out in real time in some major clinical trials.
Yeah, the trials in our source deck on this are fascinating to read through because it isn't just theory anymore. They're proving this in the clinic right now.
Right. So, for example, there is a double-blind clinical study from CenterWatch. They are combining an erbium YAG laser with estriol cream.
Estriol, that's the really mild one, right?
Yes, it's a very mild, ultra-low dose estrogen. The protocol they're using is pretty intense. Patients apply the cream every single day for 14 consecutive days just to prime the tissue.
Okay, so that's the fertilization phase.
Exactly. Then they drop to twice weekly, and they keep doing that twice weekly application throughout their months of laser sessions.
They never stop.
They never stop the estrogen.
And researchers in Brazil are putting this exact dynamic to the test in a massive 3-arm trial.
Yes, the Brazil study is brilliant.
They divided postmenopausal women into 3 groups to watch this priming happen in real time. One group gets the CO2 laser plus a placebo cream.
So just the laser.
Right. Another group gets the active estrogen cream plus a fake sham laser.
Just the cream.
Exactly.
Right.
And the third group gets the active laser and the active estrogen cream.
That kind of trial design tells you exactly where the clinical community is heading with this. They're no longer trying to figure out if lasers are better than estrogen.
They know they both do something.
Right. They are working to prove that stacking the therapies is the ultimate protocol to reverse chronic progressive atrophy.
But okay, this is where the narrative in the sources gets incredibly complicated.
It really does.
Because we have this amazing synergy, we have these promising trials showing massive improvements in quality of life. But these energy-based devices are wrapped in a thick layer of controversy.
Massive controversy. We really have to look at the regulatory landscape here. Back in 2018, the FDA issued a very stern, very public warning.
Yeah, I remember reading that.
They contacted 7 manufacturers of these energy-based devices and explicitly warned them against marketing their lasers for vaginal rejuvenation.
Why? Just because of the wording?
Well, citing a significant lack of long-term safety and efficacy data for this specific use case.
Right, because originally these devices were FDA approved for totally different things, like destroying abnormal cervical tissue or, removing warts.
Exactly. General tissue ablation.
Not for treating the chronic everyday symptoms of menopause.
And the major medical bodies aligned with that FDA caution. The 2020 position statement from the North American Menopause Society, or NMS, explicitly states that energy-based devices are not recommended outside of clinical trials.
Not recommended at all.
Right. They point to documented adverse events.
Yeah.
While they may be rare in the hands of a really skilled practitioner, they are serious when they happen.
Like what?
These include severe vaginal scarring, adhesive agglutination, which is when the tissue walls actually stick together, and persistent or worsening pain.
Oh, gosh. Okay, I am completely confused now. If the FDA is actively warning against them and the major menopause societies are saying, do not use them unless you are in a closely monitored trial, why is this such a booming field?
That's a great question.
Who is actually walking into a clinic and getting these treatments if everyone is saying, hold off?
This brings us to a critical subpopulation of patients where standard medicine has effectively hit a wall.
Okay.
Breast cancer survivors.
Uh,
For many women, local estrogen is perfectly safe. But if a woman has a history of estrogen-sensitive breast cancer, her oncology team is incredibly wary of introducing any estrogen into her system, even locally.
right, because their cancer was literally fed by estrogen, so putting it back in any form probably feels like playing with fire to them.
Exactly. But the nuance here lies in the specific oncology treatments they are on. So some survivors take a drug called tamoxifen.
I've heard of that.
Tamoxifen is a fascinating molecule. It's a selective estrogen receptor modulator. It basically acts as an estrogen blocker in the breast tissue to prevent cancer recurrence, but it actually mimics estrogen in the endometrium.
Oh, weird. So it has dual personalities.
Yes, and because of this unique profile, some oncologists will carefully allow tamoxifen patients to use ultra-low-dose local estrogen after a lot of shared decision-making.
Okay, but there is another group of cancer patients where that door is completely shut, right?
Yes, women on aromatase inhibitors, or AIs.
What do AIs do differently?
These drugs work by completely starring the entire body of all estrogen, period.
Oh, wow.
And because they are so fiercely effective at depleting estrogen everywhere, these women often suffer the most severe, debilitating forms of genitourinary syndrome of menopause.
Because they have literally zero estrogen.
Zero. Yet local estrogen is almost universally forbidden by their oncologists. It's just considered too dangerous for their cancer risk.
So their soil is completely barren, to go back to that metaphor, and they are expressly forbidden from using the fertilizer.
Exactly.
What do they do? Just suffer.
This is where the non-hormonal, energy-based devices become an absolute lifeline. For a cancer survivor who cannot use estrogen, lasers and radiofrequency devices offer a way to stimulate tissue remodeling and bring blood flow back to the area without introducing a single hormone.
Because they're just using heat.
Right. Just heat and thermal stress.
Yeah.
Yes, the devices are investigational and they carry FDA warnings. But for a woman in severe pain who has literally zero other medical options, the risk-benefit analysis shifts dramatically.
It totally does. That puts the FDA warnings in a completely different light. Like, if you have other options, maybe you wait for more data. But if this is your only lifeline to living a pain-free life and an oncologist is giving you the green light to try a laser because creams are off the table, you take it.
You take it. It's about quality of life at that point.
Now, understanding how powerful this local tissue remodeling is actually explains one of the most bizarre things I found in our source stack today.
Oh, I know where you're going with this.
It's wild because dermatologists are noticing this tissue thickening effect too, but they are using it in a completely unexpected place.
You are referring to the off-label trend of using vaginal estrogen cream as a facial filler.
Yes, people are literally putting vaginal estrogen cream under their eyes to fight wrinkles.
It's definitely a trend.
At first glance, it sounds completely absurd. It sounds like a weird internet rumor you'd see on a sketchy forum. But based on everything we just discussed about how local estrogen works to rebuild collagen and thickness, there's an underlying logic here, isn't there?
The science absolutely holds up in theory. We know local vaginal estrogen safely thickens the vaginal epithelium and restores elasticity.
Right, it plumps the tissue.
So dermatologists like Dr. Gendler, who is mentioned heavily in the sources, have noted in their clinical experience that it seems to have a similar plumping effect on the extremely thin, delicate skin under the eyes.
Well, yeah, if it rebuilds the foundation of one thin epithelium, it makes sense it can rebuild another.
Exactly. Dr. Gendler notes that for perimenopausal or postmenopausal women, using it very sparingly around the eyes likely poses minimal harm.
Sparingly being the key word.
Yes, but the sources also contain a strict, non-negotiable warning from Dr. Agbai about where this trend goes horribly wrong.
Right. Because human nature, people tend to think, if a tiny dab under my eye works miracles, let me just slather this all over my body to look 20 years younger.
That is exactly the problem. The danger arises when people start applying this estrogen cream to larger surface areas,
Right.
like the abdomen, the thighs, the buttocks.
Just treating it like a daily moisturizer.
Right, hoping for widespread skin rejuvenation. But the moment you apply a hormone cream to a large surface area, you vastly increase the systemic absorption.
Ah. So the local estrogen is no longer local.
Exactly. It bypasses the targeted approach and enters the bloodstream in massive amounts.
And by doing that, you are inadvertently bringing back all the dangerous systemic risks of full-body hormone replacement therapy, like the blood clots or the endometrial risks we talked about, with absolutely zero medical oversight.
You are basically dosing yourself with systemic HRT without a prescription or monitoring. It's incredibly dangerous.
So the takeaway for you listening is crystal clear. If you are going to use it, keep the vaginal estrogen off your thighs.
Please.
Keep it localized to where it is intended, or maybe a tiny speck under the eye if your dermatologist explicitly gives you the green light. But it perfectly illustrates why understanding the mechanism of a drug like where it goes, how it absorbs, and why it was designed that way is so critical.
It all comes back to respecting the highly localized nature of these treatments, whether it's cream, a laser, or an injection. They are powerful tools, but they require precision.
Which brings us right back to our main mission today. We've covered the painful reality of GSM, the cutting-edge tech of lasers and PRP, the complex web of FDA regulations, and the amazing lifeline this offers to cancer survivors.
It's a lot of ground to cover.
It is. And the ultimate answer to our core question, should you pause your estrogen before an energy-based or injectable treatment, is a resounding no. The future of this field isn't a battle between traditional hormones and sci-fi lasers.
The future is synergy. The ultimate protocol relies on using local estrogen to prep the tissue, fertilize the soil, and create the ideal physiological environment so that the energy-based devices can actually achieve maximum regenerative success.
It's about giving the body the building blocks it needs before you ask it to rebuild the house.
Exactly. But it is vital to remember for you listening that while this synergy is incredibly promising, many of these energy therapies are still strictly investigational.
Right, they aren't standard of care yet.
They aren't. And they carry steep out-of-pocket costs and inherent risks. Shared decision-making with your doctor is absolutely essential, especially balancing those FDA cautions against your own specific medical history.
It's a complex landscape, but honestly an incredibly hopeful one for millions of women who've been suffering in silence.
It really is. But, this raises an important question to think about. We've seen how hormonal priming can physically restructure local tissue in the pelvis to respond better to trauma and regeneration.
Right, the fertilizing the soil concept. Wait, if we can prime tissue in one specific area before a procedure, getting it perfectly biologically ready to heal, could we do this everywhere?
That's the million-dollar question. Could this localized priming principle eventually be applied to other aging tissues in the human body before a major surgery or intense physical therapy?
Wow.
If we can unlock the body's ability to heal itself through localized prep work here, where else might this synergy work?
That is absolutely mind-blowing. Imagine prepping a knee joint or a spinal disc or torn ligaments with a localized chemical primer for weeks before a surgeon even touches it.
Just changing the cellular environment completely before the intervention.
If we can get the body ready to heal itself before the trauma even happens, the days of the untouched, clean slate approach to medicine might be numbered everywhere, not just in gynecology.
It's a fascinating frontier.
It really is. Thank you for joining us on this deep dive. Keep questioning the standard protocols and keep learning.